Hello everyone and welcome to our module on hypertension. Hypertension is generally defined as a blood pressure greater than 140/90, although lower values are sometimes used in high-risk populations. And one thing that's important to know about making a diagnosis of hypertension is that you need more than one measurement. If you monitor the blood pressure of a patient over 24 hours, you would see that it goes up and down throughout the day. So you don't want to base therapy on a single high value. You want to see what the blood pressure is doing over time. In the clinic, this means that you need at least two measurements. Most patients, about 90% or so that you see with high blood pressure, have what's known as primary, or it's sometimes called essential hypertension. The etiology of this disorder is not clear. Less commonly, patients have secondary hypertension. I talk about this in a separate module. Most secondary hypertension is due to chronic kidney disease, but there are a number of other causes. Even though we don't know the cause of primary hypertension, there are a number of established risk factors. If you have a family history of hypertension, you are more likely to develop the condition. It's much more common among people of African American race. If you consume a high salt diet or lots of alcohol, you are more likely to develop hypertension. In fact, if you ever see a patient who has resistant high blood pressure that you can't seem to treat, you should ask them how many drinks they are consuming per day. Often they are drinking many alcoholic beverages, and this is raising the blood pressure. And then finally, obesity and physical activity are also associated with hypertension. Let's talk about the association between dietary sodium intake and hypertension, because there's an important and high-yield tie-in here with renal physiology. Your body tightly controls the plasma sodium concentration at 140 milliequivalents per liter. It does this via the renin-angiotensin-aldosterone system and through ADH release from the pituitary gland. What this means is anytime you consume excess sodium, your body will retain water to balance the sodium out and keep the plasma sodium concentration normal at 140 milliequivalents per liter. So when you go out and eat a high sodium meal, for example, if you consume hamburgers and french fries like I've shown in this picture here, your body is going to respond to that by retaining water. The way this works is the excess sodium consumption leads to a slight rise in the plasma osmolarity. This is sensed by the body, and ADH release increases from the pituitary gland. This leads to the retention of water by the kidneys, and thus the plasma sodium concentration stays normal at 140 milliequivalents even though you are taking in more sodium. There's a price that is paid, however, for maintaining this normal plasma sodium, and that is that water retention has occurred and there's been an increase in the effective circulating volume. When the effective circulating volume goes up, this can raise the blood pressure, and this is the mechanism by which consumption of high salt foods can lead to hypertension. And in parts of the world where salty foods are routinely consumed, there is a high incidence of hypertension by this mechanism. We do a lot of screening for hypertension, and the reason is because it's one of the silent killers. It's an asymptomatic condition, but it can lead to deadly disorders. It is strongly associated with the development of stroke, heart disease, including myocardial infarction and heart failure. It can also lead to renal failure. It's also a risk factor for aortic aneurysms and aortic dissection. Most of the disorders associated with high blood pressure are vascular disorders. They're diseases of the blood vessels where the blood vessels become sick over time from exposure to high pressures, and this leads to things like myocardial infarction and stroke. So let's talk about the specific effects of hypertension on blood vessels. This is particularly important for you to know for step one of your boards. So first of all, hypertension can lead to accelerated atherosclerosis. Atherosclerosis is a buildup of lipid and fibrous plaques in the vessel walls. It is these plaques that can rupture and lead to stroke and myocardial infarction. Hypertension can also lead to arteriosclerosis. It sounds like atherosclerosis, but it's a different process. This is a thickening of the wall of the artery, and it's a response to chronic hypertension. There are two types of arteriosclerosis that can be seen among patients with hypertension that you should be familiar with for step one of your boards. The first type is called hyaline arteriosclerosis. If you look at this picture on the screen, shown is a blood vessel with hyaline arteriosclerosis. Hyaline means glassy appearing, and this pink glassy appearing material is evidence of hyaline arteriosclerosis. It's a thickening of the small arteries that is believed to be caused by leakage of protein materials out of the vessel wall in response to chronic hypertension. You can also see this with aging. It's also seen in patients who have diabetes, but it's common and very widespread among patients who have hypertension. There is another type of arteriosclerosis that can be seen in patients who have hypertension. This type is much less common than hyaline arteriosclerosis. This is called hyperplastic arteriosclerosis. In this condition, the arteries begin to look like an onion skin. This is an example of hyperplastic arteriosclerosis shown on the screen here. This only occurs when hypertension is severe. Usually the diastolic blood pressure needs to become over 120 for this type of arteriosclerosis to develop. It's sometimes seen in cases that are referred to as malignant hypertension, meaning that the blood pressure rises rapidly and very significantly over a short period of time. What's happening in this situation is that the blood pressure has gotten so high that the basement membranes are replicating, and that leads to this onion skin appearance. And what's important to know about this is we'll talk in a few slides about how severe elevations of blood pressure, like a diastolic pressure over 120, can lead to symptoms. Usually hypertension is a silent killer, but if the blood pressure gets high enough, symptoms can occur. And these symptoms can include eye problems like retinal hemorrhages and exudates and papilledema. It can also include other problems like kidney failure and myocardial ischemia. And the reason that those things happen when the blood pressure gets markedly elevated is because the blood vessels undergo this process. This can lead to ischemia and many of the complications of severe hypertension. Another microscopic process that can be seen in chronic hypertension is called arteriolar rarefaction. This is a loss of arterioles. Recall that the arterioles are the arterial vessels that supply the capillaries, as shown in this picture here on the screen. And in patients with chronic hypertension, arterioles close off and get resorbed over time. This leads to a lower density of arterioles in patients with chronic hypertension compared to normal patients. Obviously, in the setting of hypertension, the systolic and diastolic pressures may rise, but what you may not be aware of is the fact that the pulse pressure may also increase in hypertension. The pulse pressure is the difference between the diastolic and systolic pressure, and this value may also increase in patients who have hypertension. For example, a normal patient could have a blood pressure of 120 over 80. This represents a pulse pressure of 40. A hypertensive patient may have a blood pressure of 170 over 100. The systolic pressure is higher, the diastolic pressure is higher, but also the difference between the two numbers, the pulse pressure, has increased as well. The reason for this is because in the setting of chronic hypertension, the arteries become stiff, and this leads to a fall in compliance, and that generates a higher pulse pressure. To understand this better, I've written the compliance equation in the top right corner of the slide. Compliance is a change in volume divided by the change in pressure for a blood vessel. If we rearrange this to solve for the delta P, the change in pressure of a vessel is equal to the change in volume divided by the compliance. When the compliance falls in the setting of chronic hypertension and stiff vessels, this means that the change in pressure will go up. In other words, anytime you push a volume of blood into a vessel, when the compliance is lower, the pressure change that's generated, which is the pulse pressure, will be higher in the setting of a poorly compliant blood vessel. Another way to think about this is as I've drawn on the bottom of the screen. With a normal, healthy, distensible blood vessel, as blood flows through the vessel can stretch slightly, and this allows the molecules to not be so tightly packed together. As a result, the pressure does not increase that much when blood flows through the vessel, and therefore you get a normal blood pressure with a normal pulse pressure, like 120 over 80 and a pulse pressure of 40. In a stiff vessel, as is seen in chronic hypertension, the vessel cannot stretch. Therefore, when you push a volume of blood into it, the molecules are very tightly packed together and the pressure rises significantly, and this generates a higher pulse pressure. Chronic hypertension has a number of effects on the heart that you should be familiar with. First of all, when the blood pressure is high, this represents an increase in the afterload on the left ventricle, and that can lead to an increase in the work of the heart. In addition, in the setting of chronic hypertension, the left ventricle undergoes a process called concentric hypertrophy. To understand concentric hypertrophy, let's suppose that this is the lumen of a normal left ventricle, and let's suppose that this is the normal wall thickness. In the setting of chronic hypertension, the wall thickness will increase, and you will get a process known as concentric hypertrophy. The lumen will be the same size or smaller than normal, but the walls will be much thicker compared to normal. This is called concentric hypertrophy, and this is a pathologic response of the left ventricle when the myocytes are exposed to chronically elevated blood pressure. As a result of this, you can get large voltages on the ECG. This is a normal ECG at the bottom left of the screen. Note that the voltage of the QRS complexes is relatively minimal. In contrast, on the right side of the screen is an EKG from someone with concentric hypertrophy, and the voltage is dramatically increased. The increase in wall thickness can also displace the apical impulse. You can detect this on physical exam. And the walls become thicker, and this can lead to diastolic heart failure. It can also lead to an S4 that you can hear on auscultation of the heart. When the blood pressure becomes severely elevated, it can potentially be life-threatening, and there are a couple of terms we use clinically in this situation. When we say a patient has a hypertensive urgency, we mean that that patient has severe hypertension without evidence of end organ damage. There's no agreed upon blood pressure value for severe hypertension or hypertensive urgency, but in general, people will call something a hypertensive urgency when the systolic pressure is over 180 or the diastolic is over 120, and frequently this is encountered in the outpatient setting. A patient comes to clinic with a blood pressure reading like this. They will sometimes be transferred urgently to the emergency room for acute therapy to lower their blood pressure. Contrast that with hypertensive emergency. This is a situation where the blood pressure is very high and there is evidence of end organ damage. There's also no definite value for this condition, but people usually use the same numbers like 180 over 120. And where this is often seen clinically is when a patient has long-standing chronic hypertension and abruptly stops their meds for some reason. They can then develop this type of blood pressure and they can become sick from the blood pressure being so high. So what are the symptoms that can potentially develop when the blood pressure gets this high? Well, patients can develop neurologic impairment. This can present as problems with vision. There can be retinal hemorrhages, which you can see on fundoscopic exam, and the patient can develop confusion, which is evidence of encephalopathy. There can also be renal impairment. Patients who have poorly controlled blood pressure can develop acute renal failure. They can spill blood cells and protein into their urine, and this is all evidence of hypertensive emergency. And then finally, patients with very high blood pressure can develop cardiac ischemia. Basically, the afterload gets so high that myocardial ischemia develops, and patients can get symptoms like chest pain. Rarely, if the blood pressure is very poorly controlled, patients can develop microangiopathic hemolytic anemia. I talk about this condition in the hematology modules. This is mostly of historical significance. Before there were therapies for hypertension, patients would develop hemolytic anemia from high blood pressure. In the modern era, we usually don't see this. This is caused by endothelial injury from the high blood pressure that leads to thrombus formation, and if the blood pressure is controlled, the hemolytic anemia gets better. You will sometimes hear people use the term malignant hypertension. This is a historical term. Years ago, before there were good therapies for high blood pressure, most cases of hypertension were called benign. These patients had modestly elevated blood pressures that were stable over many years. A small subset of patients, however, had what was known as malignant hypertension. This was a rare form of hypertension that was often fatal. These patients had severe elevations of their blood pressure, like diastolic pressures over 120. The condition was rapidly progressive and usually fatal over 1 to 2 years, and these patients would die from all those complications of severely elevated blood pressure we talked about before, things like renal failure, retinal hemorrhages, and cardiac ischemia. In the modern era, when people use the term malignant hypertension, they usually mean a patient who has severe hypertension that's difficult to control. And that concludes our module on hypertension.